thanks for having me. By the way, that was an extremely cool intro. I feel like I need an intro animation like that now every time I join a Zoom meeting. Awesome. Well, I'm really excited to be here and chat a little bit about AI implementation of what actually looks like in enterprises. Like Ali said, I feel like we hear a lot about AI and we see cool demos, but it's very hard to see what it actually looks like when people are using it on the front line. So I'm really excited to join these folks who are going to tell us a little bit more about what that actually looks like. I'm going to do a horrible job doing the intros for you all because I think you have more illustrious careers than I could ever fit into like a very quick soundbite. So maybe just to kick things off really quickly, if we could just go around and say who you are and what your role is, but then also maybe like something interesting you're using AI for in a personal context. We'll get to the fun enterprise stuff later, but like, do you use AI tools in like interesting personal ways? So maybe we can kick it off to Sandy to kick us off.
Yeah. Hey, everyone. Sandy Gupta, co-founder, president in the organization, and been now a decade plus since the company got founded, and been working with customers day in, day out in this transformation exercise. So happy to be here. One cool way that I'm using AI, nowadays I don't type my email replies any longer. One trick of the trade I have found is that, okay, the mail comes in, I'll just dictate something and then it'll just format it, copy paste, and it just shoots off. So ton of time saver. Otherwise you would stack up those emails. You would remember to the end of the day that these are my tough mails. I will respond when I got that half an hour. Now that is not needed. So I guess from an executive world perspective for us, the pajama time is back to us in terms of that you can now draft your emails on the fly. So that's one way I'm using it. Amit, over to you.
Thank you, Sandy. Amit Khanna, I'm lead healthcare business here at Salesforce. Based in San Francisco, I've been 11 and a half years at Salesforce, last 8 years in health. On a personal level, I use AI. I'll give you two interesting examples, not one. Nikhil, one is how to design the new bathroom I want to have AI give me a design for the new bathroom extension. And second one is to how to place new characters or new locations into a picture that was originally shot so that I can have more memories with the context around what happened during that trip, basically. So those are the two ways.
You're going to show up to your bathroom and it has no toilet.
It's like hallucination. It can be hallucination. No faucets. No faucets. It's a bathroom with no. It might not have the context and not the data. So let's figure that out today.
Exactly. All right. Last but not least, Simon.
Thanks. Hi, everyone. I'm Simon Nazarian. I'm the System Executive Vice President and Chief Digital Technology Officer here at City of Hope. For those of you who may not be familiar with City of Hope, we're one of the largest and most advanced cancer research and treatment organizations in the United States. And, we are one of the leading research centers for diabetes and other life-threatening diseases. And we have presence nationwide, about driving distance for 86 million Americans. And let's see, I've been here at City of Hope about a year and a half. I won't bore you guys with the background of all the places I've been, but the way that I'm using AI is my wife's an architect. So I am helping her do a lot of renderings using AI. And
Cool.
It's pretty cool, just taking something that's 2D and turning it into a 3D rendering. It's been a really interesting use of it. And I've realized that it also helps me make my PowerPoints look more cool using the same technology.
Amazing. Yeah. I told you guys this, but I just had a newborn. And so my use of AI has been trying to figure out what is a normal baby sound and a not normal baby sound. So that is my personal use of AI. So maybe to kick things off, one of the quotes that I sort of see thrown around a lot is this idea that 95% of Gen AI pilots deliver zero P&L impact, right? So there's all these cool demos, but when you start implementing it, it's actually hard to figure out where in the P&L that this is actually impacting. And I'm curious if this is actually matching what you all are seeing on the ground. Like, is it all just vibes, or are there actual savings that are being generated today? Maybe we could go in reverse order. Simon, if you want to kick us off on ways that it's maybe actually impacting the P&L today, or is it sort of just still in experimentation mode?
Absolutely. This statistic resonates, because many pilots start with the technology, and a lot of times they're not clearly defining the problem or the endpoint you're trying to get to. I mean, and if you think about it from a playbook perspective, right now you have, the board is mandated that you use AI, and therefore that mandates transits through the team, and then a bunch of pilots get built, and then all of a sudden the pilots they all stall. Why? Because the value is just never materialized, right? Wasn't thought through as a holistic approach. Whereas when you think about it, especially in the context of healthcare, winning playbook is that you got to start with the business outcome, right? So, for example, in oncology, value often compounds over time. Right? You're looking for gains in speed and clarity upstream that prevents costly delays, rework, downstream harm, etc. But when you start with that business outcome that you're trying to drive, you redesign the work into a way that it's within your workflows and it's really supporting. You have good, senior leadership ownership of it, and you're starting to build at scale from day one. Then now you have the real differentiator that you're not part of that statistic is because whether the use case is anchored in a decision that meaningfully affects care, operations, or research, right? Now you have something tangible to deliver on and report on.
And so when you think about business outcomes for you guys, is that like throughput of patients through the system? Sounds like speed is a part of it. Like, what are some of the ones that you guys are thinking about?
Well, for us, being not only a research organization and a care delivery organization, right? First and foremost, we want to be able to accelerate our research, right? Because we now have the ability to scale our clinical trials and have more, remedies in the hands of the folks at a more vulnerable time of their lives. But also at the point of care, being able to remove the burden from the doctors so that they can, really practice at the top of their license. One simple example is onboarding. When we get referrals from that come to us with 3,000 pages plus of clinical notes. Well, we have capabilities using AI that we are able to take all of those notes, summarize them for the doctors, and as Sandy said, reduce that pajama time for the physicians, right? That's a clear example of something that's tangible, that I'm saving 2 to 3 hours per patient for a physician, right? That means more time with the patient, et cetera, et cetera.
Awesome. Sandy, Amit, like 95% aren't doing P&L stuff. Is that something that you're sort of seeing also?
Yeah, and I think there was a McKinsey report on this as well, right? Which got quite a bit of traction earlier this year, which said that 80%, 85% pilots are going. See, that's my personal. If I would say the very definition of the word pilot means not succeeding, it will not succeed. And as because I have talked to you about it, but all the other customers as well, call it phase one. Just don't call it a pilot or a proof of concept, because the moment you call it as such, it is meant to fail, because pilot maybe project in terms of like defined populations and like defined use cases. When you put it up into a real, so your pilot could be very successful, by the way, so don't get me wrong, your pilots could be successful because they're just so constrained and well defined. But once you put them into the real world kind of a scenario, and when you are talking about the real world scenario, it's not just one EHR, it's tens of EHRs you're supposed to work with. You're supposed to interact with now patient CRM systems, and you are interacting with ERP systems. And that's where not having the right context part of it, or call it the middleware, if you will, having a inconsistent middleware ends up defining whether your pilot is scaling up into production mode or not. And that is pretty much what we are seeing across the board in our customer kind of like different case studies as well. That pilot was to Simon's point, during the course of it, you could lose your executive champion. You could like have so many other organizational changes happen that, okay, something else came up the kind of priority order, so to say. But at a very high level, I think the common denominator that we have found is the lack of that context layer or the middleware that can help scale from pilot to a scaled up kind of a setup is how I would think about it, Nikhil.
Cool. Amit, anything to add?
Yeah, no, I think similar story. I think what we have seen is, I agree with the pilot word, Sandy. What we have seen is that if the thinking is not there about how will you take it to production, where is your context, where is your data? If you have not thought through it, pilot is testing technology, but in the real world, the data is coming, the context is coming somewhere. If you have not thought through that, then it will automatically fail, because as soon as you go into product, it fails because there's no context, there's no data. So if you have not thought through that, that's the reason of those. If you're just testing technology for the sake of testing, yeah, you can call it pilot and do it, but it's not the real world answer. So I feel if people don't do that differentiation, then that McKinsey report is right, because yeah, you did not think through it, so it will fail, basically.
So name of the conference is context. It's come up a couple of times here. What is, I'm curious, like, what does it actually mean practically for organizations to actually set up the context, right? Is it that they have all these different systems and the data has to be normalized in one place? Is it that they're not even connected to these various systems? Is there missing context in a lot of cases? Like, everyone talks a little bit about like context and AI ready infrastructure, but what does that actually mean in practice? Like, what are organizations actually doing to get there? Maybe can go in reverse order this time. Amit, if you want to kick us off.
Yeah, so for us, when we look at this, context is very important from two. For me, first context is, do I know the patient? Do I, as an example, patient or a member, right? The context for me, do I know them? Context for me could be in the health payer setting. Do I know their benefits information? Do I know the insurance side? How do I know them? For me, context is simple. Do I know them? Do I have information in my boundaries, or even in the systems that I can connect to, that I know them? So knowing is important. That's for me is the context. Now you can ask subsequent questions. It goes through things. So for me, it could be context that is, you have connected the right information. It could, I'm not talking about technological terms, or it's standard data set, or it's SQL, or this state Postgres, not about that. It's about knowing whether it's structured or unstructured, doesn't matter. For me, it's, do you know the person? Do you know what you're going, that information? So that's the context setting for me. And it could come in any different scenarios. It can come in structured data, unstructured data, or whatever those aspects could be. And more importantly for me is that context allows us the downstream successful nature of delivering AI value, because context will help you remove hallucinations, basically, because you will ground things into it because you know where it's coming from. That's how I look at it. But I don't know if Sandy or Scott, good to see you, Scott, joining, might want to add.
Yeah, I can probably take that on. But Scott, great to see you. I see that you cracked the security code by joining through your phone and not through your laptop.
It only happens when you're talking on a data and AI thing where I can't actually log on. So of course.
Of course.
Join us. But to that question, Nikhil, the way that I think about the question that you asked on what is context, right? So if you think zoom back and like think about what are when you think about the AI infrastructure per se, I kind of like divide it into three distinct kind of areas. There is the data component of it, there is the context component of it, and then there is the models component of it. And like each one of them are very distinct. For example, data is all kind of your legacy system of records that exist. These could be your ERP systems, EHR systems, claim systems, and what have you. That's context. It is like on top some kind of a common data model will, so that you know that what belongs to which area, and there is no kind of simple things like duplication. So there is, like, when we say about context, at least at Innovaccer, we think of it as a strong orchestration kind of mechanism, but gradually it has also increased to include governance, security, and compliance. So the context part of it, which is the mighty middle in this entire AI infrastructure, includes your kind of ontologies, it includes your governance, it includes security and compliance. And then the final piece is your models, which are all these LLMs and SLMs that we can think about, which are important from a Gen AI perspective. Now, one question that gets consistently asked at the entire journey, what's the level of kind of A into each one of them? I would put it as, like, let's say data is 60% of the journey, the models are only 10% because the models are, as you had players about Nikhil. I know that you spend a lot of time on the infrastructure side.
No, I agree. I think, you guys have really covered that, infrastructure does create the conditions for success, right? You got to make sure that you take care of that, and we also talked about that, having good targeted use cases also, really increase the ability to demonstrate value and drive adoption. But there's one more thing that is really, really important for us to really talk through as part of this is governance. And let me tell you what I mean is that, and maybe we consider that part of the infrastructure, but creating agency and AI agents and generative AI, et cetera, is becoming easier and easier. But monitoring and controlling and governing it is becoming increasingly difficult. Right. So I think that as part of this context, it's really important for us to be cognizant of the fact that, the privacy, security, compliance, man in the middle, all of these things that goes along with governing and monitoring all of these things is also an important aspect and part of the infrastructure, per se, that we need to have in place in order to ensure continued success. Because if you want to scale it, you got to have these things in play. Right. And I mean, I'll go down, I won't go down the path, from an oncology point of view, but, you want to be able to make sure you're capturing all the biases. We talked about that, right? All the validation checkpoints. And these things can't be just sprinkled on or bolted on. It's got to be fundamentally built into the structure as you push it through. And now you have something that will, can continuously be optimized. And you have the trust and of the physician that it's reliable, right, in the real world, and it can be utilized.
I've been red teaming hospital chatbots for the last year, trying to get free appointments. So if it hasn't been catching on for you guys, let me know, because I'll test out the systems for you. Scott, do you want to actually also quickly introduce yourself, and then if you have anything?
Yeah, sure. I'd be happy to. And again, I
infrastructure?
apologize to everyone who has who's joined today for being so late. But I'm Scott Nordland.
Oh, so close.
So
We almost had him.
We lost him again.
Oh, Scott, we were so close.
A lot lately for the announced strategic integration. We're excited that that'll be our first foray outside of California, creating our Upper Midwest division. Prior to that, very quickly, I was the Chief Strategy and Growth Officer at Banner Health. I was the EVP Chief Corporate Development Officer at Select Medical. And then before that, the EVP Chief Growth Strategy and Innovation Officer at Trinity Health. So, a long career primarily on the delivery side in both for-profit and not-for-profit settings. And so, just to maybe tag on to what Simon said, and I'm kind of, I'm coming in hot here. I didn't even hear the full question, but I will tag on to, I think, when we're looking at this right now,
Yeah, he's technically challenged.
R.I.P. Scott. The real agents were messing up your phone the whole time.
Oh, so you couldn't hear me?
No, you got cut off a little bit, unfortunately.
I'm not sure where.
Pretty much at the beginning. after your career.
We lost you at Banner.
All right, I'll skip my introduction. You guys can look that up on LinkedIn.
Yeah.
So, what I was jumping into saying is, following on to what I thought I heard Simon say, was that, for health systems, I think responsible adoption, it really requires solving two huge institutional problems at the same time. One of those is trust, and Simon mentioned governance, but it's really, can we govern, monitor, and defend the AI we're deploying? So huge in this equation because we've got to know that AI tools are safe, approved, governed, monitored, credentialed, compliant, and defensible as we put them into play in clinical situations that involve human lives. So trust is enormous. The other huge institutional challenge right now.
Yep.
In the interest of time,
Yes.
I'm gonna keep moving. Scott, hopefully the internet on your side comes back in a little bit. We heard the first one, but I'm gonna keep moving just for the interest of time for now. We talked a little bit about trust, governance, all that. There's actually a question in the chat kind of around this, which is, frontline workers are obviously a big part of how the deployment is actually working, right? So it's not just we throw it in and then see what happens, but it actually materially changes a lot of their own workflows. Curious, when you all are sort of thinking about how deployment actually works, how are you actually sort of involving the frontline staff into some of these deployments? What is their general response been to some of this stuff? And just curious, like, are people excited about these changes and rollouts, or is there a lot more pushback than you expected? Maybe Sandy, if you want to kick us off on what it looks like for across some of your different clients.
Yeah. So I can, from a frontline workforce experience perspective, I could speak kind of third party to what we are seeing at our customer sides, or let me make it a little interesting. Let me speak about from an Innovaccer perspective, that how did our staff and everyone else respond when we introduced this entire AI kind of interesting kind of like component to discuss here. Like at a very high level, unlike any other, and like again, we are a tech organization, a front AI tech organization. So it's like taken almost pretty much for granted that we are using every AI tool which is around there. Any other language models that you can think of, leave no model behind is the kind of commentary that we have internally. So all our employees get access to it. And when we did that, let's say 18 months back, there were a ton of these applications and everything that were getting introduced, and non-engineers were happy. The sales team were happy. Hey, you know what? We wanted this mock-up or this kind of slide. We can now do it ourselves. We need not work with the solutioning team. So there were some of these initial successes that came in. So I think, Nikhil, to your question that you were asking, you need to tie back the AI kind of use case to impacting the day-to-day life of the individual, be that on the sales, marketing, customer success. And I'm talking from a non-healthcare, like from a generic kind of perspective, till the point in time they can see it helps them out. There is generally a good kind of an adoption rate. I think the challenging part ends up being where, as a part of the AI, you have to do a process redesign. And I'll give you an example. Let's say we as a company have to do massive data integrations. And what we ended up doing was that, let's say it's a 7-stage process. And if you install, let's say, or bring in AI in each of the steps, you improve productivity by, let's say, 20% or 30%. But since it's a 7-step kind of process, the net gain is still 0.2 times 0.3 times 0.2. So the net multiplicative number is still a fraction of the gains that you were looking at. The real gain can only come in when you do a process redesign and say that, okay, I don't need now 7 steps. I need really 2 steps. And I'm going to use AI to identify the remaining steps so that you can get a net saving out in terms of time and in terms of like the cost that the customers would have to bear. So like a slightly longer answer, but like tie it back to the frontline worker so that they feel motivated. It is helping them do the like job faster. But I wouldn't be surprised if that doesn't improve your productivity. The productivity will eventually improve only when you do the process redesign, and that has to be a part of that equation.
Yeah.
Simon, curious from the hospital side.
I mean, I think Sandy did a really fantastic job articulating. The bottom line is that organizations, very often underestimate how critical workflow alignment is, and that these tools fail not because the technology doesn't work, but because they don't match how the clinicians actually practice, right? And how your patients are engaging with you. And that's really, really important. And that's why we call out governance as another gap, right? Because when you're with proper governance, you're capturing these things, right? And then and then you're continuously validating all of the work that it's going. And once once you establish that and you're actually close to how work is done, then you have a much better chance of success and adoption and trust, right? Especially in the world of healthcare, trust is extremely important, right? And that's why, as you begin to roll these things out, another concept that's increasingly become important is the notion of change management, right? It's the training and the clear ownership and accountability and all of the things that really drive the trust for adoption is really important.
Just to maybe get a little bit more specific on use cases that people are rolling these things out, I'm curious, where are some of the areas where AI is actually delivering on its promise within a 12-month time span? And then what are areas that seem to be more like tar pit ideas? Like everyone thinks it's going to work and it's going to like change this entire process, but actually it's much harder than people think to do that. Maybe Amit and Scott, we can kick it over to you. Amit, do you want to kick us off on like what are some areas where it's like working in a 12-month time span?
Yeah, definitely, Nikhil. So I think what we are seeing is two distinct category of use cases which are prominently coming up to answer your question as like, what is that? So one use case that we are looking at is the contact center and help and triage kind of use cases, where whether it's a contact center in the hospital settings or the contact center in the insurance business settings, which is handling cases, summarizing it, automatically reading the next steps, or self-service, or simple FAQs that, do you have parking, or where can I go? Can I do an FAQ? So self-service where people would have to call the contact center or do this, that's one bucket. And within the contact center, making it automated, for example, transcription to summarizing to action, so that our frontline employees are not typing things and making sure they are more productive. So it goes back to the previous question you had with Sandy, like how are frontline workers? So we see them because they feel that this is not the exciting part of their job. The exciting part is to help patients and members. And this technology helps them go back to the exciting part of the job, then to do the non-exciting part of the job, which is typing and making things. So that's one. In case of hospitals, and we are looking at, and scheduling is the second most important use case. If you look at scheduling, waitlist, optimizing, when can I get an appointment, whose doctor is accepting. So how do you make it so seamless? Today, getting an appointment in a hospital settings is a lot of work for an individual. If you're especially asking for new care settings, not a continuing care scenario. So those are the two big bucket use cases we are seeing where customers are seeing a lot of value and bringing people back to the exciting part of the job of helping patients and members, then doing the system entry work.
It's always mind-blowing to me that like you see headlines on people finding new drugs using AI, and then also simultaneously saying things like, I can book an appointment slightly more easily now with voice agents. Like the juxtaposition sometimes is so jarring to me, but it makes a lot of sense.
It's think of this way. Sometimes the simplest things are the most value driven for people. Like if I can get my doctor to give me an appointment, if I can get an easy explanation of my claims, if I can get easy answer to why I was charged, can I get a simple answer? Is there a parking lot when I'm coming and bringing my father along? Like these help you. These help you get care. Like sometimes those things affect more personal lives than the macro. It helped me find a new drug, basically.
Totally. Scott, you want to jump in on just like 12? And maybe if you go off video, also it might be better from a connectivity perspective if you want to try it out.
Okay, let's try that. Can you hear me right now?
Yes, sir.
Mm-hmm.
Okay, so when we think about how to deploy AI, we're thinking about it across three buckets.
First bucket. Should we guess?
It was not the camera.
It was not the camera.
Yeah, we should ask him if he's on Verizon or I'm just kidding.
Exactly. All right, Scott.
My guess would be number one is administrative. But Simon, what's your guess? What was Scott going to say?
I don't know what Scott was going to say, but how about if I pinch hit while
Please,
he's
please,
kind of
Please.
coming in and kind
please.
of talk about a little bit about what what good looks like, right? And an example of that is what we deployed, we call as Hope LLM, which is our proprietary generative AI platform that's specifically designed for oncology care. Right. It synthesizes large volumes of our fragmented data and all the referral data, and it kind of brings it into a clinician-ready summary and insights that really helps reduce administrative burden, but is also improving clinical decision making and enabling clinical trials matching. Right. And we have natural language processes on top of it, so at point of care can actually engage with the data, etc. And it's been adopted very clearly across our organization. And the reason is it's really improving and taking away from the administrative burden on the physicians, but also gives them a chance to focus at the point of care. Why? Because we started with the physicians at the onset. We brought them in closer. We made them part of the process of helping us define what can we do to make your life better. And then we also, when we talk to our patients, we also realize this is helping them as well. Because you're coming in, you ask them a million questions about your condition. Right now, imagine that those questions just carry through with you throughout the system, rather than having to answer the same questions over and over again. So, how did you arrive? How did you don't want to repeat that? And for those of us who've been patients ourselves, you know how difficult that is. Especially imagine you're dealing with a chronic disease and a life-threatening disease like cancer. Right, so that's been an example of a good way of starting with the problem in mind and just kind of working it through with the stakeholders at hand. And we're very proud of it because all this data is really also contributing to a lot of other work that we're doing around research and everything else that goes along with it in a longitudinal way. So that I'm happy to share that example as what good looked like and why.
I used to work at a clinical trial startup. Also, I guess maybe I never introduced myself, which might be useful towards the end of the panel. But my name is Nikhil. I run a company called Out of Pocket. We do a bunch of content around healthcare, a bunch of events. We teach a bunch of courses on how healthcare works and all that kind of stuff. But I used to work at a clinical trial startup actually, and one thing, even when at that time Amazon had just come out with like a NLP. They're sort of like the initial NLP software, and we were doing a lot of clinical trial matching against protocols that we get in, and it was like pretty good. But it also made me very acutely aware of just how much of healthcare, especially on the clinical trial side, is just free text data matching, whether it's between the notes and the trial exclusion protocols, and it just like lives in this ether of like clinicaltrials.gov or PDFs or all this kind of stuff. And I think now using LLMs, it's been amazing how far they've come, and totally new types of people can do it, right? Like now even a doctor, frontline staff, etc., can just dump these things into an LLM and answer those questions themselves without needing to go to a data team, which I think is
right.
Important.
And imagine you're coming in as a patient and we already have identified what clinical trials you may be a match for.
Yeah.
Right. And I mean, that in itself has tons of value.
I agree. We're going to go to audience questions in a second. So if you have any, put them in the chat and we'll come to them. But maybe one or two more questions before we keep going. We talked a little bit about agents and sort of these AI tools, etc. A lot of the examples we've been talking about are human in the loop examples, right? Like, hey, it speeds up a process, but there's a person sort of at the other end who is verifying it, all that kind of stuff. I'm curious if there are any processes that you all have tested where agents can actually finish a full workflow without a human in the loop successfully. So maybe Sandy or Amit, if you guys have been working on some of this stuff, like, are there any full autonomous agents that you've seen work well?
Yeah, no, great question, Nikhil. I think the best case scenario is only the administrative tasks that you can hope can get done. Even let's say not today, even let's say 5 years. 5 years is too long a time, but let's say in a couple of years as well, I doubt that clinical use cases will fall in that domain. I doubt. Administrative are getting there. If I think, but from today and here perspective, truth be said that even if you look at the entire workflow, there are very few administrative tasks as well that do end-to-end autonomous without being human in the loop. There is always a human in the loop, and that's not by accident, it's more by design. Because all said and done, we have been talking about AI for the last 4 years now, with all the uh, discussions around Gen AI, this, that, and everything else. But if you think about, I think the answer depends on that. How do you define the workflow? For example, let's say if you're defining a workflow as saying that you need to do a follow up for a patient who has not got an annual wellness visit done and schedule an appointment for that patient. It's not just one workflow, it's like 4 or 5 sub components that somebody needs to first of all create a list of patients who have not had an AWV. Then you need to do an outbound, then you need to capture the response, you need to then connect back to the scheduling system, you need to then have a schedule done, and then you need to send a confirmation. By the way, all this information should be back into the EHR, because when the patient shows up, there should be context which is already available for the provider at the point of care. Now, this entire workflow which is there, are there 3 parts of that 5 part problem that have been automated, or let's call it agentified? Answer is yes, but there is definitely human in the loop, or as to how we call it internally, human on the hook. Because now it is much more there, they are much more on the hook to deliver that outcome, is how we like to think about it. But zoom out view, I don't think so there is an end-to-end process that is fully kind of agentified, autonomous, whatever word you want to call it, but there are sub components of it that are definitely automated.
Amit, what about you?
Yeah, I agree with Sandy, because I think if we split the use cases, clinical and administrative in healthcare, and even the only administrative work is where we think that as AI agents can help a lot, but also there we don't see it at 100% autonomous. I'll give you one example, like Sandy gave scheduling, a referral, which Simon also talked about. So referral, if you look at it from a referral perspective, there are a lot of steps. There's an intake, summarization, capturing information. Would you accept the referral? Is the insurance coverage that is there is part of, that you accepted? Is it covered? And then finally schedule, because at the end of it, referral intake is not the end goal. End goal is to get the patient the care, basically. So these are like 6 or 7 steps. But like what we are thinking is, can we do the first 3 steps in an autonomous way, which means, faxes come in, I can extract the information, I can put it into the right queue, I can, through clearinghouses, check the insurance, validate the benefits, and put it into the queue specifically for the human. Okay, this referral is ready for human review. So I cannot still do the end part. The last file is still human in the loop, but I've done the first 3 parts agentified, so that, again, going back to the original example, the fun part of my job starts now, because now I talk to the patient to give them the care. Previous part was me extracting information, writing it into the system, and all that we have taken away. And I think that's how we have to think about humans should always be in the loop, at least the technology today, and probably next 6 to 12 months. I don't know, as Sandy said, 5 years, probably nobody knows. And when technology changes every 2 weeks here these days.
What are we doing about the fact, for people whose fun in the job is doing the eligibility check against the clearinghouse? Because
we have automated it. That is automated, because we have automated to the point that we take the referral and we check against certain parameters that are these things covered. Like, do I even have sometimes the referral doesn't even have the patient insurance information. So we have automated that part. Let's collect the information. Because that's our structure. If you go back to the original question, Nikhil, you asked the context and the data. If we have the context, we can do the job. And let's do the job, which is the least, I would say, hallucination in that, exactly, because we know the structure, we know the context, we know the endpoints, we can get that information. Let's do that.
Awesome. Well, in the last 5 minutes, I do want to make sure we get to some of the audience questions. There's one question around patients sort of moving between systems. So a lot of the context stuff we talked about today is probably context you have to build within your own system, right? But what do you do about the fact that patients are going to other hospitals or other clinical settings? their data lives in a bunch of different places. We would love to, for example, maybe just have full chart retrieval and context in one place. But part of the reason we ask a lot of those patient intake forms 5 different times is because things have happened and we don't know, right? So I'm curious sort of like how you all are dealing with the fact that your context may not have the other pieces that are outside your organization. If there are ways you're addressing that, or if that's sort of a problem that continues to exist.
Yeah. Probably I can take a first swipe at it. Like, see, interoperability has been the age-old problem in healthcare, and it's not a technology problem. It's much more an intent problem. And till the point in time, we are capitalist, and I hope so we remain capitalist if this problem will exist. Again, I'm probably not answering the question that's been asked, but see, the bottom line is that EHRs, there was a EHR layer. EHRs, each one of them were motivated to keep the data to themselves, despite the meaningful use to and all those kind of guidelines coming in place where they have to give you access to data. They will make it incredibly tough, despite their participation in multiple kind of forums and everything else. We have at Innovaccer at times dealt with PDFs that we have got as endpoints that, okay, you are transporting data X to a location Y. Here are PDFs. Now you figure out how do you want to ingest it into the next system and how do you want to use it, right? So it's an intention problem. I kind of think that, however, if the patient wants to do it, the tech today allows that they can download their own kind of record to their own kind of whatever app that they're using, blue button, and there are a bunch of like kind of texts that are there, and then they can like onboard into the next system that they're going for. If you're looking for a board, I think the systems that play well with each other operate data much easier, but it's all knowledge is how I would think about it. If the systems are competing heavily and they don't want to share data with each other in that kind of a scenario, then for a new system will have to those form. Filling up the form can be automated. That it's more kind of yeah, your data gets sorted, then they might in your past system. But Simon, I would love to hear your thoughts on it, because I know that from a City of Hope perspective, their second opinion and everything else, you deal with this problem day in, day out. So how does that problem pan out in your world?
We try to ask upfront, where have you been? And we ask them to bring all their notes to us. But we also engage in health information exchange as much as possible in order to try to scour to see what we can. But, I think you called it, Sandy, that there is no national way of just grabbing this information. In my earlier days, I was leading the effort for Care Connectivity Consortium, which was at the onset of healthcare interoperability between Mayo, Kaiser, Group Health, Geisinger, and Intermountain Health. These 5 decided to get together, right? And we're still fighting the same challenges. The technology behind it, the matching all of these have become much easier, but nonetheless, you still are trying to. It's a guessing game of where people have been, unless they're forthcoming around it, etc. And it's something that I am hoping that we will continue to attack fully. The more longitudinal view of a patient that we have, the better off we will be. And as an organization, we try to construct that the best we can with what's available today. But it's not a technology issue. This is really more around legal governance and all of the things that go along with it in order to make the information readily available, including consent.
No one cares what the moderator thinks, but maybe I'll give one interesting, I think, maybe answer to this, which is I think one of the problems has always been that interoperability always tries to attack this from like a enterprise sort of like B2B standpoint of like, how does one provider get data from another provider? And I think actually the stuff that's become more interesting is, what does it look like for patients to actually get more access to their own data through different means? So now we have stronger sort of permissioning around being able to access your data through your portals, and there's like I think a lot of movement now on being patients being able to pull it through the HIEs. So if any of you have tried using ChatGPT Health or any of these consumer-facing stuff, now it's still janky for sure, but you can actually pull some of your data in. But on top of that, a lot of the context data, I think, is actually being generated out of the hospital itself. Like the number of people who are triaging their own symptoms through ChatGPT becomes its own sort of context that they can bring from point A to point B. So I am actually very interested to see if maybe this problem gets answered from a different angle, which is patients actually bringing their data with them with the context itself.
Yeah.
So that's my one answer to the question that I basically asked myself. Well, I think we're out of time.
Yeah. And I was saying the word is spoken. That's a perfect answer, Nikhil.
Yeah. I think we're out of time, unfortunately. I appreciate everyone for joining us today. If you have any follow-up questions for anyone, you should shoot any of us an email if you can find it.